Hello, everybody. Welcome to another edition of the AFR EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire. And today I'm joined by our Medical Director, Dr. Kim Pruitt.
Hi, Chief.
Welcome, Doc. And we're also joined by Lieutenant Corey Land from Station 16.
How's it going, sir?
Thanks
you all
for
for having
us.
me. Absolutely.
Absolutely. Thanks for coming to talk with us. You have an incredible case. Read through it before we sat down to meet, and I was just in awe about the care that you guys provided. And this was for Rescue 16. And you guys were dispatched out to a 24 Delta 2 at a single family residence, so an imminent delivery. Aside from the dispatch, any other information that you were able to get, and talk through with us what you're thinking as you're en route to a call like this?
Yeah, so when the dispatch came out, it was a 24 Delta, so obviously the highest acuity pregnancy call. And just from my experience on these, they can kind of range from, we have plenty of time to get to the hospital, there may be contractions and things of that nature, but we're not going to deliver on scene to, we get on scene and we can't even put on our gloves in time because baby's already on the way out. So when we got into the truck, I opened up my computer and our alarm room did a great job of noting that this was a possible breech delivery. So as soon as I saw that, I kind of started thinking that most likely this was going to be a delivery out in the field, because if someone's calling it a breech, they're probably seeing presentation of baby that isn't necessarily baby's head. So we started, on the way to the call, I started looking up our breech protocols, because to be honest, this is kind of one of those low frequency, high acuity events that I had never seen before outside of a couple of paramedic school scenarios and whatnot. Some major takeaways I took from that protocol is that we need to be aware of a nuchal cord around baby's neck. Obviously, we can't visualize baby's head in a breech, so we need to make sure that baby's airway isn't compromised. To pair with that, kind of creating a V placement around baby's mouth and nose to kind of give it a little bit of space from that birth canal area so it has a little bit of room to breathe. And then other big takeaway I got was to not have mom strenuously push, which is kind of counterintuitive to what we think on most of our pregnancy calls. But reasoning for that, and correct me if I'm wrong, is just with baby's head and neck still, kind of not delivered, we don't want to cause any sort of injury to that area. So I went over those type of things with my driver, Jeff Clark. So we kind of had a game plan going in of what I expected from him, what we were going to do. As we were arriving into the neighborhood for the call, alarm room came back across, confirmed with us that this was a breech delivery. So they said they already had feet present. So we kind of knew going on scene that, we were gonna probably be delivering out in the field. So we arrived into the house, front door was already open. We walked down a hallway. At the end of the hallway was a bathroom. So we had bathtub and toilet on one side. Dad was sitting on the toilet, kind of supporting part of the baby that was out. And then mom kind of was braced up in a semi-squatted position on the cabinets. And we had baby exposed probably up to the upper abdomen, kind of lower chest area that we could see present. So right away, my driver, Jeff, he did a great job of checking for a nuchal cord, which wasn't present, which was good, and then kind of creating that V placement. We told mom we didn't want her to strenuously push, but just, she had an urge we'd do so gently and more of kind of let gravity do its thing, especially with her positioning. And I started spitfiring off questions to Dad as I was getting the OB kit ready. So we got some good information. We learned that patient was 39 years old, so made it a geriatric pregnancy, which, has kind of a higher likelihood of potential complications for the pregnancy. We learned that baby was at 33 weeks, so a little bit premature by about a month and a half to 2 months. This was mom's first ever pregnancy, and then another big takeaway that we got was that mom had foregone any sort of prenatal care since about the first trimester on. They wanted a full, natural at-home delivery, whole pregnancy process. So last ultrasound had been done about 6 months before this. So we, they didn't have any indication that baby might be in the breech position or any other complications that they may be facing. About 2 minutes into us being on scene, baby did fully deliver. We had a towel already placed out on the ground, ready to go, so we placed baby down. My driver, Jeff, he did a great job of clamping off the umbilical cord, getting that cut. I started trying to vigorously warm baby and dry baby off with the sterile B sheets, as well as suction baby's airway with the bulb syringe, starting with the mouth and then going to the nose. And kind of the thought behind that is we always want to do the mouth first, just in case there's any aspiration that baby may have. we can get that mouth cleared first. That way they're not, potentially breathing in whatever sort of, mucus and everything that they have. Pretty much from baby delivering, we noted that baby was not in good shape. She was, I like to describe it, she was like completely as blue as my shirt. No purposeful movements, no facial grimacing. We didn't know any respirations on her, and we couldn't palpate for a pulse. So we started working baby right away. Jeff started doing compressions. We worked at a 3-to-1 rate, and I got the BVM. We started providing some positive pressure ventilation to baby. This went on for about 2 minutes in the bathroom, and then I made the call to get us moved out, kind of out of eyesight of mom and dad. Reasoning for that was that, mom had just gone through a traumatic event of delivering baby, and now she's seeing us work baby in front of her. I didn't want any sort of an adverse stress reaction that she might have in seeing that. Another kind of unique factor to our call is that we were on scene by ourselves for the first about 8 minutes of the call. So we weren't able to directly provide any care to mom, which ideally we'd want to do, but since we were so focused on resuscitating baby, we didn't really have that option at the time. So I just told dad to monitor mom, that we'd have other people on scene soon, and that if, there was anything that changed, for him to call out to us. So we worked our way around the corner, still working baby. About another minute into doing compressions, our engine and then AES showed up at the same time. So we had several people go back to mom. I directed AES's medic and a couple other personnel to go back, check on mom, and then I had a couple of other hands on with baby. So we were able to get pads on the baby. At that time, we noted an initial rate at about 64 beats per minute. Still couldn't palpate pulse or anything, so we just kept working baby. And really our chief focus was just BLSing the whole call. 99.9% of the time on these neonatal resuscitations, it's going to be respiratory based. So we weren't necessarily going down, needing to get a line established right away, needing to get meds on board. It was just kind of, working on that positive pressure ventilation and providing those compressions. There was really no indication that, mom might have been a drug user or anything, but we were still cognizant not to provide Narcan to baby, just because on those neonates, we can get pulmonary edema and seizures if we do provide that Narcan, so we wanted to stay away from that. After that initial rhythm check, about a minute and a half to 2 minutes in, we checked for a rhythm again, and we noted a rate at about 120 beats per minute. So after we saw that, we made the decision to make an immediate transport to the hospital. So AAS, they had 3 personnel on board, which was great because one of their attendants already kind of had the gurney set up and ready to go. So once we had the 120 beats per minute, I called out to the medic who was with mom that we got pulses back on baby and we should get going. So she came out. We loaded baby onto the gurney. We had our engine stay behind with mom. She was vitally stable. She was doing okay. So we had them call for an additional transport unit to transport her to the hospital, and we got baby in the back of AES's unit to initiate down to Loveless Women's, it was only about 5 to 7 minutes away, which was good for us. We did compressions for about another minute in the back of the ambulance, and then we were able to get an O2 saturation probe on the baby as well, and we noted that we had a rate of about 180 after the minute mark. We were able to palpate at the brachial a rate that matched with that, as well as on the saturation monitor, and then those initial oxygen saturations were in the 60s. So, we were making progress from what we had initially. We stopped compressions at that point. We kept providing that positive pressure ventilation with the BVM, and by the time that we had gotten to the hospital, baby was at a rate of about 200 beats per minute, which was great. Color had come back in the baby quite a bit, was totally pink through the trunk, the face, and most of the extremities. She was moving a little bit, making a couple cries, and purposefully breathing on her own. So by the time we got her to the hospital, I put her at an APGAR of about 6 to 7, so a lot better than when we first got on scene. We were able to deliver her over to staff at the hospital, and then Rescue 9 brought in mom shortly after. Again, vitally stable. She hadn't delivered the placenta yet or anything like that. So all in all, it ended up, working out in the end. But
Incredible. The way you described the case, like it feels like you were there and you can see it. So fantastic job. These are not calls that we regularly go to. I think Lieutenant Land touched on that, like the high acuity, low frequency events. So with that breech delivery and process, when we arrive there and we see limbs or anything else protruding other than the head, luckily, like nature worked its course and the baby started to work its way out. What should our providers be thinking about in terms of how long before they initiate that transport, if that's the presentation on arrival?
Yeah, what an amazing call. So in terms of a breech delivery with presenting parts present when you get there, I think you had a couple of things working in your favor on this call. One is that the baby was very early and probably pretty small. And so I think in that instance, I would hang around for a minute or two and see how it's progressing, to give a chance to deliver at home rather than try to move mom and do everything together, especially when you're by yourself there.
Right.
So I think if you're anticipating a smaller infant waiting for a little while, the other thing, I'm glad you mentioned it too. I was thinking when you said it, her positioning.
Right.
The fact that she was able to use gravity, I think that innate sense of how moms have that. I think sometimes, and as physicians, I know we're guilty of working against that sometimes and flipping people on their back and putting them on the ground. But I really like the fact that you let gravity do some work there, with the gentle pushing. I think those two things really worked in your favor. But if anybody else, hopefully no one is in this situation, but with other breech deliveries, if it's a more advanced later into the pregnancy, maybe a known larger baby, a smaller mom, with a smaller pelvis maybe, or in a different position, it is also okay just to try to load mom and the baby together and try to get to the hospital, because there are some breech deliveries that don't progress and that head does get stuck because the cervix doesn't have time to fully dilate. And that's why you don't want to push, because when mom bears down, it squeezes on that little baby neck. And so no pushing, and then just letting her go, because they don't always progress like yours did.
Right.
So.
And during transit, just making sure that we're keeping that index finger to keep that baby's airway open as best we can, right?
Or pressure. So theoretically, the baby could still be getting oxygen delivery through the umbilical cord. And so if you keep, just kind of like you would do for a nuchal cord, if you can keep pressure off of that cord, if it's not stuck with the cervix and around the neck, and then trying to keep that airway, supporting the airway with the two fingers and the head and the neck. If you can try to put your finger into the baby's mouth and like pull that chin down to decrease the AP diameter of the head, and then guide the head out as well. Some maneuvers that you have. It sounds like it's a good thing that the dispatch gave you some warning so you could think through all of that before you got there.
Our dispatch did awesome with that, because, walking into that completely unaware of what's going on is a lot different than at least having an idea, getting to look up protocols before and kind of formulating a game plan before we got on scene. So, yeah, they did a great job with that.
Another reason it's so fantastic to just have the guidelines just at your fingertips, right, on the app, and then you get good information from the dispatch center. Gives you that 3-4 minutes during your response to be able to be ready for what you're walking into. So you guys did an incredible job. He hit on a great point in regards to, like, he had an APGAR basically of 0, essentially, with that baby. But they held off. They took the whole history into account, but they held off at administering Narcan, right, to reverse anything. And why is it important for providers to remember that neonates, we shouldn't give Narcan?
This is the one population where we know that it causes harm. Even if we know that the mom just took a bunch of fentanyl and the baby comes out not breathing, it's easy to think, oh, Narcan may help this because the baby has fentanyl on board. What happens, just like you mentioned, can cause seizures or pulmonary edema and make the situation worse. And so really just focusing on good BLS, which is what you did here.
Yeah,
warm, dry stimulate when the baby first comes out. Keep them warm, especially the preemies. And if they don't respond to that initial stimulation in like 30 seconds, then you move to positive pressure, ventilation, and your CPR if the heart rate's less than 60, which is exactly what you did.
And even you're outside the box thinking, because the positive pressure ventilation was key, but then knowing, oh, we have a heart rate that's showing 64, but I'm not palpating that, so let's continue to prime the pump to make sure that they're getting the circulation they need.
Yeah, absolutely. And that was kind of the thought process behind it.
Incredible job. I would assume this is the first time you had a breech delivery and a call you responded to?
This
right?
was, yeah. So I had a couple of field deliveries before this, but nothing like a breech delivery, yeah. Like I said, paramedic school, we had a couple of scenarios, and that was sort of all I knew of it before that case or before that incident, so.
And then calling for the resources early. You guys, I think, did a great job by focusing on the baby because he was in the or she was in the most need at that time, but still keeping mom being aware that she might have some care needs, and then bringing the next crew in to address her. I thought it was a great call as well.
So.
I couldn't find any, but just if you were to have this call again, or if you were talking to a new officer who encountered this, anything you would add, change, delete on how you address this call?
So I think for us, really, the way it ran, and just kind of given our situation of just myself and my driver being on scene, I think we really did as best as what we could with what we were working with. I do think for anyone else that's in this scenario, or even just a normal field delivery, it's just important to remember that mom is equally there and needs equal care. And 99% of the time, we have the resources to be able to provide enough hands for baby and for mom. So not to neglect mom. I know these can be exciting calls where we kind of tunnel vision into baby, but it's really important to make sure we're getting those vital signs on mom, getting an IV established, making sure that there's no massive hemorrhaging or anything like that we may be going into on that. Just if we had the extra hands on scene, we would have definitely got to mom a lot sooner. It's just kind of the circumstances of the situation. So
yeah, deal with the highest acuity first.
Right.
Fantastic job. Incredible case. Thank you for taking the time to come share it. I think you guys handled
Absolutely.
it amazingly, and I hope a lot of people take some good notes off of this event, so that when they encounter that call, they act the exact same way and perform. So it was fantastic.
Thank
good
you.
job.
Thank you very
for
much.
sharing.
Excellent.
Absolutely. Thank you.
That's all we have for this case today. If you have any interesting cases you'd like to share, you can use the SharePoint tab to do your case submission or reach out to anybody from the EMS division. Until then, we'll see you next time. Thank you.